Well, welcome everyone. This is session 1.3 to make sure you're in the right place. This is the session on addressing the healthcare workforce crisis through labor management coordination or collaboration. The session is sponsored by the Healthcare Industry Council, which is a group within LIRA that brings together people interested in employment relations in healthcare. If you have an interest in healthcare, please consider joining the Healthcare Industry Council. You can do so if you have a LIRA membership account. You simply go into that account and indicate you wish to be a member of our industry council. There's no dues or costs involved. But you will be informed occasionally of opportunities to participate in webinars on healthcare, and it's a great way to connect with other LIRA members with the same interest. So with that announcement, let's get started. We have three presentations today. Let me introduce the speakers for all three first, and then we'll get into the presentations themselves. The first presentation will be by Zach Zobris, who is currently the Director of Workforce Development for SEIU Healthcare Pennsylvania. And I should mention that he's also a former faculty member at Penn State University's Labor School. The second presentation will be by Will Erickson and Michael Pachinda, who will be doing a joint presentation. Both are from the University of Massachusetts Medical Center in Worcester, Mass. Will is with the SHARE AFSCME union there, and Michael is a labor relations representative for the medical center, and they're both fully engaged in the partnership at that site. And Polly Pittman will be making the third presentation. Professor Pittman is the Fitzhugh Mullen Professor of Health Workforce Equity at the Milken Institute School of Public Health, George Washington University. We should have time to take questions afterwards. If you do want to ask a question, hit the hand up sign on the web page, or just wave at us and we'll give you a chance to ask a question. So we're going to go in the order that I introduced folks. Zach Zobris, over to you.
Thanks, Paul. I took this down just so we could all see each other, and there we go. So yeah, I'm excited to be here, and I'm also really excited to, actually what I'm most excited about is to hear from Will and Mike and Polly, but happy to have the opportunity to share. I've spent 21 years in the labor movement, as Paul mentioned. 3 of those were on faculty with labor and employment relations at Penn State. The other 18 have been in the field with SEIU Healthcare Pennsylvania, played a variety of roles. Probably seems like every role in the organization, including executive officer roles. But our union created a workforce role a year ago, and it enticed me to want to come back because I feel like, as you'll hear in the presentation, that kind of through innovation and deeper thinking in workforce, there's real opportunity to actually improve patient care, improve labor relations, and grow our labor movement, grow the union. So that's what I'm gonna kind of share some of my thinking on, and some of the work that we're doing in Pennsylvania. I just to note, for folks that aren't close to the healthcare industry every day, or though I think we're probably all aware from headlines and things, but there is a real crisis in workforce. In Pennsylvania, we get worried about a real collapse of just care delivery because of these workforce challenges. So the uh, Surgeon General is sounding the alarm here. This is just from a few days ago, talking about the crisis. And what I would just note is that I think maybe for a person in the public, they might think, well, COVID's been what, almost 3 years now. Things must have been bad then. Well, for healthcare workers, the challenges on the front line are actually greater now in terms of staffing and workforce challenges because at the very start, actually hospitals shut down. Elective surgeries were delayed. Well, as expected, there's a lot of pent up need for those services, and healthcare workers have been leaving. So I just wanted to share a little bit more about what some of those challenges are. Our union focuses on acute care and long-term care, and so I just want to touch base on those two industries briefly on what the challenges are before we think about opportunities for change. So this is just to note again, this slide that the industry headlines in their in Becker Review and the emails that go out to the industries every day. Pretty much every day, it's talking about the workforce challenges. And again, this is coming from the American Hospital Association, from surveys of CEOs that staffing and workforce are major concerns, and staffing actually is the number one concern, and it's the first time that it's been that in 17 years. Just to kind of drive this home, a survey done by the USCF Health Workforce Resource Center looked at who stayed and who left within different industries, and then with healthcare, found that a third of the folks, so many people left or were just disrupted at the beginning of the pandemic, actually in healthcare, and a third of those folks in roles like home care, direct care worker, personal care aide, CNA, did not come back to the workforce. And so it's been a major challenge. And we've seen that in Pennsylvania. Our local went from 6,000 kind of nursing home members to 4,000, lost about a third of folks. Same number of facilities generally, but just less workers. And that aligns with the fact that the industry here in Pennsylvania noted that about 70% of their facilities have closed beds because of staffing, and in hospitals as well. They're also, because of staffing, not accepting patients at times, a quarter of the time. And the RN vacancy rate is growing, up to 9.9%. Nurses continue to talk about leaving at the rate of 71%. And the big challenge in hospitals is actually that nurses are leaving because they're going to go work for an agency. You used to travel across the country. Now you can travel to the other part of the city that you're in and earn 3 to 4 times as much as you did before. And that's been caused major disruption in the workforce. And I'll just note this, Polly, I think, is going to talk a lot more about this, but because of these challenges that folks are facing, a recent study in Pittsburgh that surveyed hospital workers, 15% of folks have pretty regular thoughts of suicide given the challenges that they face. So that's just to make clear the crisis. And I think the question is this a moment for systemic change? And I'm gonna just say a few comments now on that, but then focus more on question number 2 about how the crisis might help us think about transforming labor relations. So I think Polly and I were actually mentioning this at the beginning. To me, it seems like the opportunity to have systemic change in the healthcare industry and for the workforce in a more robust and deeper way than we've had before. Public awareness is high. Workers' expectations for change is high. There's been some additional funding with ARP, and we know that systemic change is hard. And from my perspective, the way, and I know Peter's on here and he's written a book about this, the way that change actually happens and best happens in industries and in healthcare is when frontline workers help to lead that change. And so that's why I think this question of, um, you know, can we take this workforce crisis and this moment to actually change labor relations and have deeper engagement of workers and management together to try to really bring this systemic change. That's the way that it's going to happen if it's going to happen. And I think one anecdote that we found in our union as we've been meeting with employers trying to talk about this moment as a way to transform labor relations. Just to note, we've got several hundred employers, represent approximately 30,000 members. And for the first time, employers have kind of said, you know what, we don't know what to do. We can't figure this out on our own. And that's been a shift right there, because often it's been like, yeah, maybe we'll work with you, but kind of we know what we're doing and we got this. And so I think the industry and management leaders saying, you know what, this is so bad that the more heads that are in this, the better, is the start of a potential shift. But what I want to focus on in my last few minutes here, which I think I have 2.5 left, Paul, is what unions need to do. Certainly there's things that I think the industry needs to do or management, but I think unions can be doing more in this moment. And that's what I want to focus my last few comments on here. Again, workforce challenges aren't new to unions, but I think the crisis has raised the urgency and maybe the chance for systemic change. And hopefully it can be a chance to bring new labor relations. So here's some of what we're doing in our union that I think is a change. We felt like as a union, this is a moment where we can actually independently or jointly engage in direct recruitment of workers, using social media, using mass texting and other things. And so we also have a grant that we're doing some of this with CNAs. And again, I think some other unions, their training funds and other things are doing this, but for our union, it's a moment where we're shifting to say, can we do more of this? And not just our training fund, but is this something the union should be doing, rather than just leaving this to management and feeling like that's their responsibility. We are engaging in trying to train and credential workers, and then thinking about what if for industrial unions like trade unions, we did more training and credentialing. So other SEIU locals are engaged in apprenticeship and trying to advance that model from the trades and healthcare. Our union recently we just got a grant where we're going to experiment with creating what we're thinking of as kind of like a hiring hall within healthcare. It will be a high road agency essentially that would respect workers' rights to organize, provide good pay, provide training and career advancement. So those are some of the things that we're doing as a union that are new. It's also led to new ideas on retention. I would just say that the conversations with employers now aren't just, certainly pay is key, but they're going beyond pay to things like childcare, transportation, loan forgiveness, things that in the past might have been something we just thought, well, there's no point in really bringing that to the table. But I think the level of ideas and engagement between union and management is growing. I think we have a lot of work to do. Partly my message here would be, even what we're doing in our union, it seems to me not enough. It seems like we're not truly seizing this moment. But this is kind of a call that workforce can be an opportunity, I think, for unions to move from a traditional paradigm to a potential for partnership, where rather than just the union gives input, we're deeply collaborating together on things like recruitment, things like promoting this employer and marketing the employer. We are starting to do that with some of our hospitals, moving from solutions that are just about money to the broader kind of work environment and systems change. that opportunity is there. Will we seize that and really move it forward? Where we shift from just thinking about bargaining as the place for change or being within the NLA box to getting into conversations with the employers about a much broader range of topics, because those are the topics, again, that are actually going to help us solve the workforce challenges. And what I hope is that through this, it shifts from kind of the union being a liability, or the union saying on the management side, or the union saying, well, you know what, this is management's problem to figure out recruitment. It's their problem to figure out retention. We've told them in bargaining what to do and they don't want to listen. That's a lot of what I've heard in the past. You know, can we start this work and then actually get to a place where the union has real joint ownership, joint decision making, and is being a value add. So that's where I would conclude my comments.
Well, thank you, Zach. Really exciting stuff. It reminds me that Lynn Williams, the former president of the Steelworkers, used to say all the time that management is too important to be left to management. And it seems the same thing applies to recruitment and retention. Having everybody's shoulder to the wheel makes an awful lot of sense. So next is Will and Michael. The floor is yours.
Great, thank you.
I'll give you a second to put your slides up.
Great. Okay, can you see my slides?
Yep.
Great. Okay. So this is us. Mike, why don't you introduce yourself quick?
Sure, happy to. Yep. My name is Mike Pacinda. I'm a senior labor and employee relations specialist at UMass Memorial Medical Center. We are a large portion of our workforce is unionized. We have, I want to say, about 12 distinct unions across the system. And so my job, the way we split up our workload, is we're assigned to cover and sort of manage the relationships with various unions. And I work primarily with the Share Union.
Cool, thanks, Mike. And I'm Will Erickson. I'm an organizer by background. Being an organizer with the Share Union was my first job out of college 22 years ago. So I've been hanging around the place for a long time. At UMass Memorial. But in the last couple of years, I've shifted my work to working in our new labor management partnership office as a partnership coach and improvement coach. So Mike, want to talk about our system?
Yeah, so UMass Memorial Medical Center is a pretty large healthcare system in central Massachusetts, where our flagship campuses are based in Worcester, Massachusetts. We have over 1,000 beds, and we are the largest employer in the region. We have over 16,000 employees. Large portion of our patients are on Medicare or other public funding, some uninsured. So we are the safety net hospital, in the region, and clinical partner with UMass Medical School, which is attached to the campus.
Cool. And the Share Union, meanwhile, is the largest union at UMass Memorial. I think there are 12 unions at UMass Memorial, but I think Share is as large as the rest of them combined or close. But the reason it's so big is because it's the union that represents a whole lot of different job titles. So respiratory therapists, billers, medical assistants, LPNs, rad techs, all kind of runs the gamut. Around half of the bargaining unit is clerical, and around half is more kind of hands-on patient care. But what that means is that a sizable chunk of the union is now in a kind of work-from-home remote capacity. The union's been around. It's affiliated with AFSCME. It's been around for about 25 years. It was organized by my friends Janet and Elizabeth and Chris. I was I started interning with the union a couple of years after this, so I can't take any credit for that. And we organized our union around the twin kind of pillars, twin values of solidarity and voice, which for us means enabling our members to participate in decisions at work about them, and giving them opportunities to take care of each other. Oh, and I should probably explain this picture. These people are unmasked. This is pre-COVID, back in the day. We're all wearing masks still in our hospital. But this is a signature poster. In our union, we take a lot of pride in knowing every single member and having a conversation with every single member with some regularity. And so something that the union often does is kind of print off a set of values or goals that they're going into a negotiating cycle with. And then they, the organizers and reps and leaders walk around and have a conversation with every member and have them sign on to that set of values and goals. And then we print it out into a big, beautiful, like gigantic, 2.5 by 4 foot poster, and wrap them in ribbon, give them out, send them to people. It's a lot of fun. Mike, want to talk about our partnership?
Yeah, I do. So let me just move this around. Yeah. So, as Will mentioned, the union had, been around for a while, back since 1997. In that time, obviously the relationship developed, and by 2016, there was really a lot of great sort of robust language in the contract, to protect workers. There was work security and income security language in there. But I guess the piece that was kind of missing was this sort of, engagement, right? I mean, still this issue of, the share members not feeling as attached to the workplace, not feeling quite as engaged. So what we attempted to do was we formed this labor management partnership in 2016, and we attempted to address some of those concerns, to bring frontline share employees in having a voice, as Will mentioned before, contributing into process improvement type work as respected partners, so sort of a hand in hand with management. And with that, we're also trying to create a culture of kindness and respect, and that's what we set out to do. So this next slide kind of talks about what we, as UMass Memorial Medical Center, why we think partnership is important. And I love this first block, right? This came from our former Chief Human Resources Officer, Bart Metzger, whose sort of mantra was, there is no case for adversarial labor relations. And I believe that to be true. As you point out, it's just sort of a recipe for institutionalized conflict, and could often, lead to, picketing, walkouts, strikes, that type of thing. So in our paradigm, that's something we're attempting to avoid. We also value the partnership because we realize, right? I mean, there are a lot of overlapping interests between management and the union, and we have worked very collaboratively in partnership with Share on a number of different initiatives. I think, Zach, you kind of referred to it as a value add. We kind of refer to it as a kind of a full force multiplier. We have partnered on certain legislative initiatives where our interests have lined up, and we've been very successful in those efforts. And then even just smaller things, kind of almost like day-to-day things. I mean, we'll partner with Share to help us amplify messaging. If there's particular, training or, town hall sort of informational events that we want people to attend, Share is great about reaching out to its membership to kind of, push those things. So we've seen a lot of success in that space. Also, trying to kind of reverse the paradigm from the, a top-down kind of management approach to bringing in frontline caregivers I had mentioned before, engaging them, giving them a real voice in the workplace, and empowering them to solve problems that they are facing on a day-to-day basis. With that sort of deeper frontline participation and engagement, I mean, that naturally leads into better patient care and better outcomes. We've been able to see that, in play regularly, and that helped us, right? So this paradigm has helped us during COVID, where we've had partnership, we've had trust, we've had communication, and we were able to kind of build on that to get through, help us get through that crisis. And, there was a lot of transparency as that last little bubble notes. I mean, we literally were talking every single day, giving updates and, trying to come up with solutions to the various problems that we were facing during the crisis.
All right, and similarly, Share also cares about the partnership, for a lot of reasons, but the primary reason is that we think it's the best way to improve our members' lives. Right? We've got a responsibility to look after our members' interests and ability to thrive, and we think this is the best way to do that. We've tried other ways, and this way seems to work best for us. We also really like the effect that partnership has on our union culture. We think that partnership enables us to develop different kinds of Share leaders. We also can see that it strengthens the hospital and makes care better in an observable way by the wider community, which gives us more pride in our work, but is also good for the hospital and good for our members' long-term financial interests. And we've also found that we've been able, through kind of repeating the action, embedding the habit, to collaborate on a wider set of issues than we might have previously thought possible, whether it's around lobbying or thinking about career ladders, things that just seemed like really hard and clunky every time we tried them before. That stuff has been getting easier over time. I also want to, sorry, I have a bad habit of narrating pictures. This is a picture of a bunch of us on a joint labor management delegation to visit our union sisters at Kaiser. We have really gained a huge amount from and support from our friends at Kaiser. They basically, like all the good ideas that you see in these slides, we ripped these all off from our friends at Kaiser. We translating is really hard, right? Translating to a new place, that's probably what a lot of these presentations are going to be about, is trying to figure out how to make an idea that worked one place stick in another place. But really, they get a huge amount of credit.
Very gracious and generous, Will, with their with sharing their resources with us, for sure.
Totally, yeah. They take the one big union thing really seriously.
Mm-hmm.
All right, so I'm going to talk a little bit now about UBTs, which we view as our really our primary strategy for retaining our health workforce. So a UBT, it stands for a unit-based team. This is a Kaiser model, one of the Kaiser things that we ripped off. For us, the way we describe UBTs is that, like, the primary purpose of a UBT, the reason this whole thing exists, is to change how caregivers feel about coming to work every day. That's the point. If we're not doing that, then it's just, another QI thing, right? And every hospital in America has its own QI shop. We're trying to do something different here. So that's the point. But the theory of change that we're operating with is that the best way to change how people feel about coming to work every day is to involve them at a deep level in measurably improving the work itself, right? And by measurable, we mean like in ways that they and others can see. So this isn't about like pulling together a department committee that like organizes pizza parties or bowling nights or trust falls or ropes courses or any of the other stuff that might raise morale. It's not just about morale. It's about deepening engagement, and in doing so, deepening pride in the work. So our aim with these UBTs is to create an invigorating work culture, to make the partnership real at the front line. Mike and I are buddies, right? Like we're pals. We talk just about every day. But for lots of our members and their managers, there's still like a much more traditional relationship. And so UBTs represent our strongest effort to date to really try to like drive the partnership to the front line. We also have a pretty specific idea in our heads of what a good QI project looks like. Oh dear, is that true, Paul? Well, then we better speak up. Which is that we really think the best improvement work goes from the bottom up, goes from the front line up. So really quick, a UBT for us, it's a department level improvement system. It's co-sponsored by the union and by usually the boss's boss in the department. It's co-led by a frontline leader, like a share member who works there, and the manager. We've really embraced lean as our process improvement methodology, but probably could sub in others. We don't let it strictly rule us. We operate by consensus, and we test for consensus using these 3 questions, which may be familiar to some of you. Has everyone in this room been heard? Can everyone live with this decision, even if it wasn't your first or second or even third choice? Will you try it, in other words? Because often our UBTs, they're not like deciding the way something should be forever and ever. They're deciding to run an experiment, right? Lean is the application of the scientific method to process improvement. So we're running experiments and learning from our own experience. And then finally, and most importantly, will everyone actively support the decision we just made outside this room with your coworkers? So these are the kinds of things that UBTs work on. And I won't narrate all these to you, but what I want to emphasize is like none of our UBTs, they're not curing cancer, right? They're working on operational issues. We encourage our UBTs to pick projects. The projects are chosen by the front line. We encourage them to pick projects around things that are like just the most aggravating processes that they experience every day. We ask them like, what are the things that are wasting your time? What are the things that are getting in the way of you feeling good about the care you can deliver? What are the things that are causing conflict between you and your coworkers or between your department and other departments? That's often a sign of like a crummy process. And I'd also point out about these, often it's not like the prescription center saved $1 million, right? That was amazing. But they didn't like they didn't go like, geez, how are we going to save $1 million? They had an inventory process that was driving them bonkers because people would show up to get their medication. The tech would say, yeah, I'll get that for you. Go to the shelf and find that it wasn't there. And it was a humiliating experience for them. It wore on them. It made them feel bad, like they were being crappy at their jobs, right? And so they wanted to fix that. As a result of overhauling their inventory process, they saved $1 million. So everyone was really happy, but that wasn't like the goal that the members had. So we think of those as like Oh, I'm sorry, Mike, go ahead.
Oh, no, I was just going to say this next slide, Will, I think is just
Yeah.
really powerful and really kind of drives home, like, are they making a difference? So in addition to those points that Will just made before, these are results from our 2020 Press Ganey engagement survey. And you can see there was some statistically significant improvements, both in the engagement and leader indexes for caregivers. That's what we call our employees, caregivers who work in UBT areas. This sort of this bottom bubble are just quotes on how our caregivers are feeling about UBTs and their work and process improvement.
Right. These are actually these are the questions on the survey that showed the greatest gap between departments with UBTs and the general population. So like, I'm involved in decisions that affect my work, and this organization treats us with respect. Think back to those two goals of our partnership, which were to enable everyone to participate in process improvement, and to create a culture of kindness and respect. So we see these as quite validating. And so I think we're going to wrap up here, but just wanted to say a quick word about why UBTs are different. This is a process improvement system, but we think that this ends up looking and feeling pretty different than most other process improvement systems out there, even though it's using more or less the same set of tools. And for me, as an organizer, I think about power a lot, right? Power in the workplace. And so for me, these are the things that make it different, right? The ownership is really shared, and we evaluate our UBTs and kind of grade them almost based on how shared it feels. We think that the union, the deep involvement of the union in these process improvement efforts brings a deeper level of credibility and accountability and relationships. The contract guarantees work security and income security. We've got really clear language in the share contract that says basically workers can't innovate themselves out of a job, which at any given moment probably feels like a pretty small fear, but it's really it's something that we used to hear from our members a lot. And we think also that our experience has been that our partnership makes it easier for us to talk about hard things. I think we were worried at first that we would have to tiptoe around each other and like be nicey nice and be like, Sunday dinner at grandma's, like everyone kind of gets along in this room. But it's enabled us to handle some really, really tricky things. I also, Mike, you want to talk a little bit about our joint recruitment efforts before we wrap?
Yeah, just really quickly, I think this almost harkens back to some things that Zach brought up and that he's working on, but we have engaged in, joint recruitment efforts. We had an event earlier this year in January where it was share friends and family. So share members invited their friends, their nephews, their neighbors, and it was just kind of a massive recruiting event. You can see the various participants there. It was a Zoom event, virtual, and a lot of those people that you see are not only share members, but our recruiters, our TA department, right, who were like actually there. It was successful. I mean, there's maybe some obstacles with follow-up, but in terms of attendance, it was really, really successful. We've also been working with Share on recruiting radiology techs, and as I'd mentioned before about Share helping us amplify messages, we have a referral bonus program in place, and Share's been great about encouraging its members to refer people to positions, and in order to get those various bonuses.
All right. Well, then I think we'll leave it there. So please be in touch.
Okay, thanks, Will and Michael. That's great stuff you're doing, and thanks for sharing it with us. Polly Pittman from George Washington University is next. Polly?
Yeah, just to check in, Paul, what time does the panel end?
12:45. So
12:45. Okay.
we'll
So
still
I'll
continue for
try to be quick because it would be really, I have a lot of questions for, especially for Will and Mike, about the potential for expanding these models outside of not just union setting, not just labor management partnership settings, but union settings, where there might be the will and what the implications are. But at any rate, let me just again introduce myself. I'm Patricia Pittman. I go by Polly. I direct something called the Mullen Institute for Health Workforce Equity at GW, which is a partnership of 7 schools at the university. We've worked on, my world is a little different from your world, and it's really exciting and fun to meet all of you. My own professional society home was Academy Health. I consider myself a health services researcher. And although I've had contact with Lyra over the years, it's not my primary home. So it's really, I think, interesting and important for us to be talking to each other across these academic silos, if you will. So a few things that I've done in the past that might be of interest to you. One is I worked with Ellen Scully Russ. Actually, this is how I met Peter Lazis on a labor management partnership paper. I'm actually going to put it in the chat, and just because I'm always interested in feedback. And this is old now, but it's it'd be interesting to think about whether there's still. I looked at Montefiore and KP and talked about how labor management partnerships were changing the role of the workforce in the context of health reform. And then I also put in the link our website where you can see a couple projects related to this topic. One is a project we started pre-COVID on moral injury among nurses, which is a participatory project, and we're looking for people who want to be involved. And another is what we call a framework on health workforce equity. And we define that and have a number of domains and evidence reviews on each domain. And we just did a soft launch of that, but the domain number 6 is particularly relevant to the work that you all are doing. It's about working conditions. A lot of my own work has been on the nursing workforce. In particular, a study we just finished was on nurse staffing laws, comparing the mandated ratios versus nursing committees versus public reporting, finding that only the mandate in California has any effect on nurse staffing levels. And I think it's sort of an interesting paper for you all, largely because the nurse staffing committees was used as a way to avoid having a state level mandate. And they, in some ways, have the flavor of a labor management partnership. At least that was the intent. And what we see is that across the states that have been required to adopt this model, there's been no impact at all, which suggests, to Will's point about whether this is Sunday lunch at my grandma's kind of a dynamic, it would appear that it's that or worse in many settings. So to this question of whether you need a union to be able to do these labor management partnerships, or let's call them worker management partnerships, it's starting to seem to me as though probably yes. But I'd be interesting to see where staffing committees had unions, if there was any difference between staffing committees that did not have unions and how they played out in terms of the very concrete measurable outcome, which is, did staffing levels change, right? We're also doing a study on union attitudes towards unions among medical residents, which will be an interesting area of expansion of organizing for the healthcare sector. So, but specifically, Paul and Peter asked me to talk about moral injury, which is an area where we're working a lot now, not just on the nursing project. Our shop just won the competition to be the National Technical Assistance Center for what HRSA was calling burnout and resilience, and what we call moral injury. We've renamed it as the Workplace Change Collaborative, and we're working with 44 grantees across the country that got HRSA grants under the Lorna Breen Act. So it's over $100 million going to all these organizations, and what we're doing is a learning collaborative across the sites. And we were charged with developing a national framework. And so I thought I would talk just briefly about that idea of a national framework around this issue. You all probably know that there are a lot of concepts out there, and there is very little work relating these concepts to each other. So, sort of a first task is to sort of understand what burnout is and what its history has been. Of course, it has 3 component parts. I'm sure you all are familiar with this. I don't have to go into all of it, but there are also less well-known concepts that have been banging around, like mattering, like second victim syndrome, which is when a provider is triggered by something in the care relationship that either relates to their own life or relates to some error that they committed in the past and can create trauma. There's secondary stress syndrome, which is just the exposure to over time to sort of human suffering and death. And of course, that's been a big issue during COVID. And then, of course, there is moral injury. And moral injury is something that came from the Department of Defense. It was really focused on the issue of returning soldiers. And it was largely identified as a sense of betrayal by those who are in a position of authority. And Wendy Dean and Simon Tabbitt in 2018 wrote an article in Stat, they're both physicians, that really brought this issue to the fore in healthcare. And they have further kind of elaborated this concept in ways that I find particularly interesting and important when we think about sort of the policy and the advocacy to address the issue of the workforce crisis. And they focus in on sort of a 3-part process, if you will, before talking about the drivers and the solutions, but just the concept of moral injury itself, which is this sense of betrayal, which could be by the employers or it could be by sort of societal values in a larger sense, society that doesn't value homeless people or Black people or people who don't have health insurance, or it could be by colleagues and by folks that are within the team, but sort of a sense of betrayal in the sense that the workplace is not allowing me, not giving me the resources I need to be able to do my job. So very closely tied to the idea of professional ethics, followed by essentially what Wendy would call choice. I don't like that word, but essentially the dilemma that a worker would have to either speak up and act out or to shut up and work under the conditions that have been dealt. And she calls that an off-ramp, speaking up and acting out. And if you don't do that, which obviously most people don't, particularly when they're not in an organization where they have job safety and psychological safety, when you don't, you essentially go into the third moment of that process, which is transgression of your ethics. And you live with that day in and day out, practicing in a way that is viewed as not by the individual as essentially violating your professional ethics. And the emphasis is on professional ethics, but one could also imagine that it extends to sort of personal ethics as well. So then the question becomes, how is this concept different and how does it fit into other concepts that have come before? What does it actually mean in terms of solutions? And I've been working with them in the context of our Technical Assistance Center to try to do this framework that will bring everything together. And I think there's now consensus that it is a precursor to burnout, that is kind of the super highway to burnout. There are some things like personal circumstances or choices that could lead directly to burnout that don't go through the superhighway of moral injury, but most things go through the superhighway of moral injury. Yet nobody's talking about moral injury. It's kind of this dirty middle space, right? Where we think that a lot of the solutions to burnout are not going to be effective because they don't understand that dirty middle space of what's actually happening in people's heads and what is leading to the burnout. So, a big critique sort of at the lay level with workers has been, burnout is blaming the individual. Resilience is a concept that sort of focuses on the individual, and this is not a problem about individuals, it's a problem about systems. I think the National Academy of Medicine now is also saying, they started saying even in 2019, it's not a problem just of individuals, but they say just, not. And now we have a draft action plan from the NAM that just came out last week, and we have, of course, the Surgeon General's advisory that Zach mentioned at the beginning. And I think there's been a lot of progress in the official discourse, shall we say, around this issue. They're really much more focused on system level changes. The Surgeon General's framework, which if you should take a look at it, if you're interested in this at all, it's figure 2 on page 12. I like a lot. It doesn't even mention the individual level. However, it doesn't mention moral injury. So in a sense, the Surgeon General is now understanding that the drivers are systemic, that those are societal and cultural drivers, health system drivers, organizational drivers, and workplace environment drivers. However, when they get to the solutions part, they're skipping over the dirty middle. And so what we've been thinking about and working on is what would actually be different about what we're thinking are solutions to the workforce crisis in healthcare that you don't get when you only think about or measure burnout, or you only think about or measure mental health. And I think this is where we come back to you all and your interest in labor management partnerships. I think that's a perfect example of the kind of stuff you'll never get to if you just have a burnout frame. This issue of moral injury requires you to think, again, at the several level of drivers, but it's fundamentally about creating a situation where workers can do their jobs. In healthcare, yes, everybody's there to get a fair salary and certainly wants to have occupational safety, et cetera, and opportunities to advance professionally. But most healthcare workers, particularly, once you get into the professional echelons, are there because of the social mission, because of the professional mission of helping people. And so when the work environment doesn't allow you to do your job, it is a deeply distressing issue that leads to burnout. And I mentioned, okay, I see you. I mentioned this morning to the panelists before we opened up the panel, that NPR had a story today on the health workforce crisis, and someone was talking about how psychotropic drugs were really going to be the answer. And it's kind of sick humor, black humor in a sense, but it is, unfortunately, they're looking for magic bullets that are going to serve to sort of, essentially remake workers into people who will comply with this warped reality that they're living. So it was, to me, just sort of a confirmation of how important it is to continue to try to change the conversation and focus on this middle space of moral injury, which, I think that a lot of unions, including SEIU and AFT, have really talked about what does it mean to be a professional union and how do we connect the social mission to our work. So given that time is up, I look forward to the conversation with all of you.
Well, thank you, Polly. Again, really interesting and important work that you and your center are doing. It's really encouraging to hear about it. Now I'm going to open the floor up to questions. If people have a question or a comment, you can either put the magic hand up in your on the website, or just wave and unmute your mic. Johnny Callis, if you'd go first, and then we'll go to Bridget.
Yeah, thank you all so much for such a great panel. I'm curious about the implications for some of the UBT work that you all have done, the fact that nurses aren't really involved. I know this is true in Kaiser hospitals in Northern California, I believe also at UMass, maybe due to sort of ideological commitments by the nurse unions to engage in traditional bargaining. I'm just wondering if there are implications and why you think that might be the case, that I know it's not in every example, but in a lot of these cases of partnership, nurses are not involved.
I can try to take a crack at a piece of that, which is to say that actually in our UMass Memorial UBTs, we have a lot of RNs who are very deeply involved, frontline RNs deeply involved in UBTs and helping to lead department level improvement work. It's true that the MNA, the Mass Nurses Association, hasn't agreed to kind of participate in a formal sense in this for a lot of reasons, but we're happy that they haven't done anything to discourage their members from participating who want to participate.
Bridget?
Yeah, I want to thank everybody too. I really appreciated the conversation. As somebody that's kind of stepped into a pretty contentious relationship on the labor relations for the employer side with the union, I'd be really curious to ask the panelists about or hear your responses. How do you I feel like there's a COVID factor in addition to a contentious relationship, and I'd love to hear your feedback on broaching the subject of some sort of a partnership with that COVID factor, right? There's sort of a, and what I'm saying when I say that it is we've got sort of pay us back for the work we've done for years, with a desire from the organization to pay you back for the work you've done for the years, but with an organization that's been impacted for what's been happening for the years. So you kind of add layers to that. I'd love to hear any suggestions or feedback you might have.
Mike, you might want to jump in there.
Yeah, I know that's a really tough question, Bridget. And I'm not exactly sure how to answer it. I mean, I think that I've been in the enviable position of working with the share union and kind of having this history of partnership that we've really kind of leaned into to kind of talk through these really difficult issues. But my colleagues, for example, who do work with the M&A, they're facing some real challenges. You know, we're in a labor market that it definitely seems to have tipped in favor of giving a little bit more leverage to employees, just in terms of you know, bargaining for wages and salary increases. We've been kind of implementing, which I haven't seen done in years, a lot of off cycle market adjustments, you know, for employees. So it's hard for me to exactly answer. So, and you know, in my experience, what I'm hearing from you know, my other colleagues, rewarding people financially is kind of the primary avenue that, you know, that's important to the membership of these various unions, and we've done that in some cases. So I'm not sure if that quite answers your question, Bridget. If there's maybe like more of a nuance that I could answer more fully. It seems like you're kind of struggling with, you do want to develop kind of a partnership model, but you have this added pressure of COVID that's kind of weighing on that and making it a little bit more challenging.
Well, so I was brought in for, I have 15 years of mediation and arbitration experience. So I do feel like the organization is really being mindful about, you know, placement or hiring, and that they want to utilize my skills. However, I'm walking into a historically contentious relationship, and then we're having to negotiate during COVID. So we've gotten, you know, the request for COVID, you know, reparations essentially. And so I'm trying to figure out ways to leverage a more kind of compatible relationship partnership while we're managing through all these other elements. And so I was sort of looking for, you know, I love the idea, the proposal. It's definitely the work that I'm interested in pursuing. But I feel the beast is big. It's COVID. It's injury, personal injury. You know, from the perspective of the work effort and the lack of staffing and all those sorts of things. So I was just curious if you had tips on how to kind of tackle that.
Polly, did you want to jump in there? I saw your hand up.
No, I actually wanted to ask you a question, Paul, about but so I took it down because I didn't want to take up the time because it was important what Bridget's doing. Sorry about that.
Okay, let's just go to Peter Lazzy's first, and I will mention some of the stuff that we're doing at the end.
So I just want to respond to Bridget and Johnny's question. First to Johnny, there are nurses unions that are engaged in partnership activity. So I just want to clear the air. SEIU, the AFT have active locals where there are nurses that are seeing the benefits of the partnership being one that's union building as well as patient centered. I mean, I think one of the questions is, can unions see this as a strategy for themselves as well as improving patient care? Including work at the University of Vermont where they're dealing with staffing directly. So I just wanted to clear the air about, are nurses against partnership or tending to be. In terms of Bridget's question, I would say that the pandemic in a positive way, God forbid, that's probably the wrong word, has created the opportunity, and I think Zach talked about this earlier, create an opportunity where management sees the need for dealing with recruitment and retention in a way that they probably had never thought about it in the past. So I think it's an opportunity to get labor and management, even in a corrosive environment, to possibly start thinking about there's some positive ways to work together. Whether it spreads to other areas, that might not be the case, but I do think there's more management now on a national level that sees that they don't know the answers to these problems. And if the union steps in and says, we're willing to work with you on that, it doesn't mean that they work on staffing and other issues. But that might be an area, Bridget, where there's a joint sense of issues, a common sense of issues that people could work on. And I think it's a real opportunity for what Zach talked about, for unions to step up to this and not wait on management for recruitment and retention, but to really take a proactive role and then seeing how that can spread. I'll also just add to one other piece that really hasn't been talked about. The structure of the partnership is as important as to keep it accountable for the results as, unit-based teams. The unit-based teams by themselves will not, and I think Will talked about this, having employment guarantees and whatnot. I think that structure is really important as a post-pandemic set of activities start.
I'm afraid we're going to have to wrap up here, and I'm going to grab the last word because I do want to mention the initiative we have at Penn State, which is an effort to bring existing partnerships together to learn from one another. We're really just a facilitator in this, but for the last 2 years, about 5 partnerships, and someone asked how many there are in the country. There are more than that. Kaiser is not involved in ours, and that's the largest. But there are partnerships at the University of Vermont, at UMass, at Allegheny General in Pittsburgh, and there are some emerging partnerships. There's a partnership in the LA Department of Health and emerging ones at some other places. There's a community, I think, of people who really believe that we are not going to solve the tremendous challenges facing healthcare unless we bring employees to the table. That's going to be an absolute necessity to find the solutions to the complex problems we have. It can't be done from the top down. We're a small initiative, but we firmly believe that it's important to get the word out, and we're very much open to working with any unions and employers in healthcare who want to explore partnership. That's really our ultimate goal, is to expand the number of partnerships in healthcare in this country. With that, I'm afraid we're going to have to wrap up. I want to thank Zach and Michael, Will and Polly, and all of the participants for what I think is a great session. There's some really exciting things going on. And again, the idea that the Department of Labor is now stepping up its efforts to promote partnership, that just gives me even more hope that we can make this a more common phenomenon in healthcare workplaces. So thanks, everybody. Great session.
I was staying, but I think we have to go because the next room's in. So
Oh, okay. Are we?
yeah, I think Deborah had her hand up and someone else, but I think he left. But
Okay.
I think the next folks are in. So I will
Sign off.
Yeah.
See you soon,
Yep, good
guys.
seeing you guys. Yep.
Yeah. Bye, everybody.
Try to join on Friday.
Yeah.
Thanks, Will.
Yeah, you bet, Peter.
Okay.
Thank you.
Mike, Polly.
All right. Stop their recording.